Roughly 40% of adults over 60 report waking with some form of morning shakiness, trembling hands, unsteady legs, a strange internal vibration that fades once they eat something or get moving. Most of them have already been told it is low blood sugar. Most of them have already tried eating before bed. And most of them are still waking up the same way every morning without a clear answer. That difference matters more than most people realize. This is not a blood sugar problem, not primarily. What is actually happening involves the autonomic nervous system, specifically a failure in its overnight regulatory function. And once you understand that mechanism, the intervention becomes very different from what you have probably been told. If you find this useful, subscribe. We are working toward 500,000 subscribers on this channel. People who want clinical explanations without the noise. Now back to this. The obvious explanation is reactive hypoglycemia. Blood glucose dropping too low during the night, triggering the body to release adrenaline as a corrective signal. That adrenaline surge causes trembling, heart pounding, and a generalized sense of agitation. It is real, it happens. The usual advice follows logically. Eat a small complex carbohydrate snack before bed, a slice of whole grain toast, a spoonful of almond butter, a small portion of oats. Sometimes it helps, often it does not. There are also other recognized contributors. Caffeine consumed late in the day raises cortisol and keeps the sympathetic nervous system elevated through the early sleep cycle. Alcohol causes blood glucose instability through its effect on hepatic gluconeogenesis. The liver's ability to produce glucose overnight is suppressed. Poor sleep architecture, especially reduced slow wave sleep, prevents the normal overnight cortisol suppression that should occur between 2 and 4 am. Dehydration concentrates circulating hormones and amplifies adrenergic sensitivity. These are all real inputs. Addressing them helps partially. The part that actually surprises people is why addressing all of them still leaves a significant proportion of adults over 60 waking with the same symptoms. The deeper mechanism is age related autonomic dysregulation, specifically, a decline in the sensitivity and responsiveness of the baroreflex and the vagal brake. Here is what that means in practical terms. During sleep, blood pressure naturally falls, heart rate slows, the body shifts into a state of parasympathetic dominance. In a younger, well regulated nervous system, this transition is smooth and well buffered. The autonomic nervous system makes continuous micro adjustments through the night, small, rapid corrections to blood pressure, vascular tone, and circulating glucose that keep everything stable. After 60, those micro adjustments become less precise. The sensitivity of arterial baroreceptors, the pressure sensors embedded in the carotid artery and aortic arch, measurably declines with age. The vagal tone, which is the parasympathetic influence on the heart, also weakens. The result is a nervous system that is slower to detect and correct overnight instability. Take the exact same physiological drop in blood pressure, the kind that happens naturally at 3 am, in a 35-year-old and a 68-year-old. The 35-year-old's baroreflex fires, makes a quiet correction, and sleep continues undisturbed. In the 68-year-old, the same drop goes undetected for longer. The body eventually overcorrects with a sympathetic surge, cortisol, adrenaline, and that is what produces the shaking, the racing heart, the sense of internal vibration. The person wakes. They assume it is blood sugar. They eat something. They feel better because food is a secondary stabilizer. But the root input was not glucose, it was autonomic timing. This is not a condition most general practitioners routinely assess. There is no morning symptom questionnaire that asks about tremor frequency, internal vibration, or orthostatic stability on waking. Standard medicine treats the surface. Check fasting glucose, rule out thyroid, reassure. The deeper mechanism is almost never the conversation. Here is the full chain. Parasympathetic withdrawal begins in the early hours of the morning, typically between 2 and 5 am, as part of the normal cortisol awakening response preparing the body to wake. In a young nervous system, this transition is gradual. Cortisol rises slowly. The heart rate increases by a few beats per minute. Blood pressure climbs gently. The person wakes feeling alert. In an aging autonomic nervous system, two things change. First, the cortisol awakening response becomes less regulated. It can spike sharply rather than rising smoothly because the feedback inhibition from the hippocampus and prefrontal cortex weakens over decades. Second, the vagal tone that should buffer against that spike is reduced. Vagal tone is measurable. It shows up in heart rate variability, and research consistently shows that HRV declines with age, particularly in adults who are sedentary, chronically stressed, or metabolically compromised. The result? Cortisol and adrenaline surge. The adrenal medulla releases epinephrine. Blood glucose is pulled up rapidly as glycogen is mobilized from the liver. Vascular resistance changes, and the body, instead of waking smoothly, wakes in a low grade adrenergic state, trembling, tight, internally vibrating. One more link in this chain, and most people overlook it entirely. Overnight, the kidneys continue to filter blood. Electrolyte losses through urine, particularly sodium and potassium, alter the electrical environment around nerve cell membranes. In a well hydrated, electrolyte replete person, nerve firing remains stable. In someone who is even mildly hyponatremic or hypokalemic overnight, the threshold for nerve and muscle activation drops. That means the same adrenergic surge produces a larger and more perceptible physical response. The shaking is louder, so to speak, because the neurological volume is turned up. Apply that same principle to the cardiovascular system. Arterial walls that have stiffened with age due to reduced elastin and increased collagen cross-linking, which is a well-documented vascular aging process, are less able to buffer the pressure wave from a sudden sympathetic surge. That rigidity translates directly into a more jarring physical experience of what would, in a younger vascular system, be a minor overnight correction. This is not a disease, it is a convergence of normal aging changes in autonomic regulation, vascular compliance, electrolyte handling, and adrenal responsiveness that interact at 3 a.m. when the body is working with its lowest physiological reserves. Here is the exact protocol. 1. Electrolyte loading in the evening, not a sports drink. A measured dose, 500 milligrams of sodium, 300 milligrams of potassium, and 200 milligrams of magnesium glycinate, taken with 300 to 400 milliliters of water, approximately 60 to 90 minutes before sleep. Magnesium glycinate specifically, not oxide because of superior bioavailability and its additional role in GABA receptor modulation, which directly supports parasympathetic tone during sleep. This is the step most people already know something about, but still get wrong by using cheap magnesium forms or inadequate dosing. 2. Slow, extended exhale breathing for 10 minutes before sleep. A 4-second inhale, 6-second exhale cycle. This is not optional relaxation advice. This is direct vagal nerve stimulation via the Herring-Brewer reflex. Research supports that this measurably increases heart rate variability within a single session. It is also the lowest friction entry point in this protocol. No cost, no equipment, and you can begin tonight. 3. Body position on waking. Before standing, spend 60 to 90 seconds in a seated position at the edge of the bed. Both feet flat on the floor. Take 5 slow breaths. This allows the baroreflex to pre-activate before orthostatic challenge. The most common mistake people make is standing immediately upon waking, which, in an aging autonomic nervous system, produces a blood pressure drop that requires a corrective sympathetic surge, exactly the state they are trying to avoid. 4. Morning electrolyte repletion. Before coffee, before breakfast, 250 milliliters of water with a small pinch of sodium and a squeeze of lemon. Cortisol is at its natural peak in the first hour after waking. Starting the day with a mild osmotic load supports vascular stability and blunts the amplitude of that cortisol peak. 5. Structured aerobic activity at moderate intensity, 25 to 35 minutes, 4 to 5 times per week. Zone 2 specifically, the effort level at which you can maintain a conversation but would not choose to. This is the primary long term intervention for restoring vagal tone and improving baroreflex sensitivity. The minimum effective duration before measurable autonomic improvement begins is 6 to 8 weeks of consistent practice. At 12 weeks, HRV improvements in adults over 60 using this protocol have been documented in multiple peer reviewed studies. 6. Alcohol elimination or strict limitation, not reduction, elimination where possible, or a hard limit of no more than one standard drink and only before 6 p.m. The hepatic interference with overnight gluconeogenesis is dose dependent and begins with the first drink. Expected early improvements within 1 to 3 weeks include reduced frequency of morning shaking episodes and a more gradual, less jarring waking experience. The longer term goal at 10 to 12 weeks is a measurable improvement in resting heart rate variability, which you can track with any modern wearable device, and the elimination of morning adrenergic surges as a recurrent pattern. A man in his mid 60s presented with a 4-year history of morning tremor and internal vibration. Fasting glucose had been checked repeatedly and was consistently in the normal range. Thyroid function was normal. He had been told, without any further investigation, that it was anxiety. He had tried eating before bed, no lasting change. He had tried reducing caffeine, partial improvement that plateaued. He slept reasonably well by subjective report. A 24-hour ambulatory blood pressure reading revealed significant overnight blood pressure variability, with two clear spikes occurring between 3 and 4 a.m. His resting heart rate variability, measured on a consumer wearable, was in the lowest quartile for his age group. Serum magnesium was in the low normal range, technically within reference, but below the functional threshold increasingly supported in the literature. He followed the electrolyte protocol and the Zone 2 exercise program for 10 weeks. Morning shaking episodes reduced from 5 to 7 mornings per week to 1, occasionally 2. The internal vibration resolved almost entirely. His resting HRV increased by approximately 18% over the 10-week period. Blood pressure variability on a repeat reading was substantially reduced. He was not cured of aging, but the physiological conditions that made aging produce that specific symptom were meaningfully changed. Chronic autonomic dysregulation is not a benign inconvenience. It is a documented risk factor for cardiovascular events. The overnight blood pressure spikes that produce morning shakiness are the same overnight spikes associated with increased rates of stroke and myocardial infarction in adults over 60. Persistently elevated nighttime adrenaline also accelerates the erosion of hippocampal tissue, the region most associated with memory consolidation and most vulnerable to glucocorticoid excess. The long term cognitive consequences of uncorrected overnight adrenergic surges are increasingly well supported in the literature. Worth raising with your doctor alongside a request for ambulatory blood pressure monitoring if morning symptoms are frequent or worsening. One question for the comments. How long have you been experiencing morning shakiness? And does it resolve with food, with movement, or does it persist through the morning? Drop that in below because the pattern of resolution tells us something meaningful about which layer of this mechanism is most active in your case. And I read these in order of priority. 7. Tonight, before bed, 500 milligrams sodium, 300 milligrams potassium, 200 milligrams magnesium glycinate in water, 60 to 90 minutes before sleep. 8. Tonight, before sleep, 10 minutes of 4-second inhale, 6-second exhale breathing. 9. Tomorrow morning, sit at the edge of the bed for 60 to 90 seconds before standing. 5 slow breaths, both feet on the floor. 10. Tomorrow morning, 250 milliliters of water with a pinch of salt before coffee or breakfast. 11. This week, Begin 25 to 35 minutes of Zone 2 aerobic activity, 4 to 5 sessions per week. Commit to a minimum of 8 weeks. 12th. This week, review your alcohol use honestly. The hepatic effect on overnight glucose is not negotiable. 13. Ongoing. Track morning symptoms and, if they are frequent, ask your doctor about ambulatory blood pressure monitoring to capture what is happening overnight. Subscribe if this is useful. We are working toward 500,000 subscribers, people who want the mechanism, not just the headline. Everything shared here is for educational purposes. Your situation is specific to you, and a real conversation with your own doctor will always give you more than any video.